we do the introduction and let us start?
Yes, sir. Yes, sir.
Yes, yes.
Aditya, would you like to say something about your thyroid conference just now or at the end of the...
Yes, sir. I just have a couple of slides which I can say at the end, sir. No problem, sir. I can say at the
Or should we do it now? So at least before starting, there should not be any problem. I think enough members are there.
Yes, sir. So
Okay.
today we are taking a case of solitary thyroid nodule being presented by Dr. Lavesh Patel from BJ Medical College. We are joined by in teachers. We have Dr. Dubhasha sir. Everybody knows him. He is at present the greatest authority at AIMS Nagpur. We have always had him, and we had the pleasure of joining him at various places. Thank you, sir. Thank you for joining.
Thank you, sir. Thank you for the opportunity.
We have Dr. Srinivasan from Coimbatore. Sir has also been a part and partial of this academic session for more than once, and I am grateful to Dr. Srinivasan for joining.
Thank you, sir.
Dr. Guru Santappa is a little busy, but he has assured me that he will be joining soon. So these three are the teachers of panel of teachers. As an expert, we have Dr. Arvind Krishnamurthy. Sir is the HOD and HOD of the Head and Neck Department at the WS Institute at Adyar, Chennai. And we have Aditya from our own HCG Ahmedabad, who is a senior head and neck consultant. With me, I have my mentor and my teacher, Dr. Pankaj Modi, to guide us through the whole process smoothly. Just putting some basic rules is that Lavesh will complete the history part, followed by it's a virtual case. He has the history, he has the investigations, and so we'll allow him to complete the history part before we ask any questions. And then again, the same thing for investigation and treatment. Of course, the teachers and the panelists have the power to stop him at any given time if they find that there is something amiss or if there is something going wrong. I think with that clarity, we should start. Dr. Krishnamurthy, I think I am clear, sir?
Yeah, absolutely clear. Absolutely clear. Looking forward. This is my first time in this forum, and I'm
I
glad
think
to be here.
one of our resident is with you just now, I think. So Josna is
many of them, sir, many of them are inspired.
Yes,
A lot
I
of
think
people from
Josna is there,
Ahmedabad are with us, and
Anand is also there, I think.
yeah, Nanda, Shweta. So both of
Shweta.
them are there, and I guess this year also somebody is joining them. So thank you for inspiring generations of future surgical oncologists, sir.
Thank you.
Krishnamurthy sir was the one who passed me in my MCH exam, so I am also forever indebted to him.
Aditya, now you are a veteran. Yeah, come on. All is history. Don't make me so old. Still as young and active. Yeah, looking forward for the discussion. Yeah.
Right, sir. Lavesh?
Yes, sir.
Please, make it full screen and start.
Good morning, sir. Myself, Dr. Lavesh Patel, and I'm today presenting a case on the thyroid swelling under guidance of Dr. Pankaj Modi, sir, Dr. Apurva Shah, sir, Dr. Vinit Chauhan, sir, Hiral ma'am, and Dr. Maulik Mehta, sir. A 30-year-old female, a homemaker residing at the Ahmedabad, presented to Civil Hospital Ahmedabad with chief complaint of swelling in the front of neck for 6 months. Patient was relatively asymptomatic before 6 months, and then she noticed swelling in front of neck, and which was approximately a marble size noticed 6 months ago and increases gradually to the current size, approximately a lemon size. No history suggestive of hyperthyroidism or hypothyroidism, not associated with pain and fever, no history of any changes in voice, difficulty in breathing or difficulty in swallowing, no history of weight loss, no history of any bony swelling, bony pain, or any other swelling in the neck. Patient is not on any medication. Past history, no comorbidity, and no past surgery in the past. No history of irradiation. In personal history, patient is taking a vegetarian diet with good appetite, having an unaltered bowel and bladder habit. Sleep is adequate, no addiction. Menstrual cycles are regular, and last menstrual period is 10 days ago. Patient is para 2 with abortion 0 and 2 live births, all delivered via the full-term normal vaginal delivery. And family history, no any significant family history. In summary, of the history, 30-year-old female patient came with the complaint of swelling in front of neck for 6 months, and which is a progressive and not associated with pain, fever, or any symptoms suggestive of hypo or hyperthyroidism, or any compressive symptoms or significant past history.
Okay, so a brief history, a very short history of just swelling in front of the neck and nothing else. Srinivasan sir?
Yeah, you're taking it for granted it's a thyroid swelling.
Lavesh, it's for you.
Sorry, sir.
You're taking it for granted it is a thyroid swelling.
Sir, it is a swelling in front of neck. Sir, I would like to examine further to say it is a thyroid.
From the history wise, what do you
Yes.
think would this? What other swellings will come into your mind? The commonest other swelling.
Sir, it is a lemon size, and I'm suspecting in the midline it
Don't
might
say
be.
lemon size and all, because each district, each state, the lemon is different size. Okay.
Yes.
So the small swelling has gone to the present size.
Yes, sir.
So, okay. So what other swellings will come into your mind if you think of this one?
It might be swelling arises from the skin and the subcutaneous tissue, like a lipoma, might be a dermoid or a thyroglossal cyst, or any lymph node enlargement.
Yeah, lymph node. Commonest is lymph node rather than thyroglossal cyst. How old is the patient? Go to the first slide.
Yes, sir. It is a 30-year-old female patient, sir.
Yes, sir. Next, anybody else, please?
You asked for history of pain, right?
Yes, sir. No history of pain.
Yeah, no history of pain. So which are the various painful swellings that you know?
In the thyroid, pain is might be due to the thyroiditis or any hemorrhage in the thyroid. It causes the pain, sir.
All thyroiditis will uniformly have pain.
Mostly subacute thyroiditis, decurrent thyroiditis, patient have a pain, sir.
The initial stage. Okay, what else? Which other thyroiditis? When you talk of the
Riddle thyroiditis also the pains.
riddles would routinely have not present as a painful thyroid swelling. Anything else? Any other
Acute
conditions?
suppurative thyroiditis.
Yes, yes. The acute suppurative thyroiditis on stage of decurrence thyroiditis. That's correct. Hashimoto is also present as a tender one. Yes. Anything else? Later stages of even the anaplastic carcinoma. Once there's infiltration into the nervous tissue, then of course you will have the.
Yes.
Yeah.
So can a cancer be associated with pain, Dr. Lavesh?
Yes, sir. If there is a sudden increase in size with the internal hemorrhage, it might be associated with pain, and involvement of the nerve and the surrounding structure, it might be a painful, sir.
Right. So a pain in a cancer is suggestive of a locally advanced sort of a thing. So generally, most of the thyroid cancers that present are or swellings that present associated with cancers tend to be painless.
Yes.
So, this is actually a very classical way of presentation of thyroid cancers also, like just painless lump in a relatively younger lady patient. This is the more. So if the same swelling occurs in a male,
yes,
what are your concerns? And anything to do with age? Now you say 30 years and a lady, like anything to associate. I think assuming I'm just thinking that it's a cancer, so in those terms I'm asking you. Of course it could be anything else,
in the male, in the younger age, chances of cancer is high, sir.
A lady with in a younger age.
It might be papillary carcinoma of thyroid is present in the younger age, sir.
No, age and malignancy. You want to tell any? What are your thoughts, papillary
carcinoma of thyroid is present in the younger age. follicular carcinoma of thyroid in the middle age, anaplastic cancer in the later age, with if there is a medullary carcinoma of thyroid, it present in the younger age, sir. If it is associated with the Mann syndrome.
I think you're more or less okay, but general association with is, at least with the well differentiated ones, it's extremes of age. Okay, so you're right that in a older age group, your suspicion of say lymphomas or anaplastics can be there, but then very young people and very old, so extremes of age, the association of malignancies will be there. And anything about the gender, you said male versus
chances of
what
malignancy.
about say for everything, with regards to age, you can have, say, ultimately when you are having a thyroid nodule, generally of course it could be anything, but then one of the main goals is to sort of rule in or rule out a cancer, right?
Yes.
So towards that, whether all these associations can sort of give you something in mind, that is what we are trying to sort of say. Now we discussed with age, we said that extremes of age could have a increased risk of malignancy. Now with regards to gender, is there any correlation?
Thyroid swellings and are more common in the female, but if there is a male involvement, there is chances of malignancy is high, sir.
Very good. I think that's right. So if you see 5 times more common nodules per se in a woman, and if a male has a nodule, then I think the index of suspicion should be a little higher. So this is with regards to the age and with regards to gender, with any evaluation of nodule. Please go ahead.
Besides, yeah, if I were to add to Sir's
Yeah.
point, it also means that the gender determines the risk. Once, if it is coming out as a cancer of any sort, then it would also mean that males are in a higher risk category as per the AJCC classification, which I'm sure we'll be discussing later on. So just the basic history would give us some pointers to where we are likely to head. So even in an examination, you might want to be more careful in a male patient with regards to the symptoms of advanced disease or the higher risk features. Yeah, please go ahead.
Yes.
Yeah, just 1 minute before that, you said that there's no history suggestive of hypo or hypo. So just to complete that discussion, can you just tell what actually you asked to elicit history of hypothyroidism?
Sir, for the hyperthyroidism, ask about the weight loss with despite of the good appetite, patient having complaint of the palpitation and diarrhea and oligomenorrhea in the female, sir. And for the hypothyroidism, sluggishness, lethargy, weakness, constipation, weight gain, and increases the menses.
Okay, yeah. So you insist on the muscle weakness and the lethargy and the fatigue. Okay. Okay, fine. Yeah.
Lavesh,
Yes.
considering it to be nodule, if it is a hyperthyroidism, what will you suspect?
It might be a toxic adenoma or the toxic nodular goiter with the dominant nodule, sir.
So is it possible in this case?
So patient does not have a history suggestive of the hyperthyroidism, but it might be possible, sir.
No, what I am asking, this is a case of nodule, and if there are symptoms of toxicity, what should be the history? How does the toxic adenoma or toxic nodule develop? What should be the history? Do you understand my question?
Yes, sir.
Okay, let me ask different way. Suppose it is hyperthyroidism. Which type of hyperthyroidism it will be?
It is a toxic adenoma, tertiary hyperthyroidism.
What is tertiary hyperthyroidism?
It is the autonomous nodule, sir.
Why not secondary?
It might be a secondary, sir, with the dominant nodules.
I don't get it. What do you want to say? Dominant nodule means other nodules are also functioning?
It's a toxic nodular goiter with the dominant nodule, sir. That might be.
No. Be specific. What do you want? When will you call it secondary hyperthyroidism?
Long-standing goiter.
Right. So can this be a toxic nodule?
Yes, sir.
So with history of only 6 months. What is usual history for a development of toxic nodule?
A long-standing history, sir.
How long?
I don't know, sir.
How does the toxic nodule develop? What will be the
Pathophysiology.
history? Because you are asking and you have asked no history of hyperthyroidism. So how will you ask history that this patient might be having a toxic nodule or toxic adenoma? What do you want to say?
There is a long-standing history with the sorry.
Yes.
There is a long-standing history of the goiter or the nodule, and that patient develops the symptoms of
Again, you are wrong. You want to say goiter or you want to say nodule. Both are not the same thing. So how does it starts? How does a patient who ultimately end up with toxic nodule will have a history start? Another question, what we should will be the age usually if patient is having a secondary hyperthyroidism?
It is the older age, sir.
Older age, and usually 5 to 10 years. And it usually starts with hyperplastic goiter, which will be diffuse. Later on, it will convert into nodules, and one of the nodule becomes prominent, then it is said. Still, I don't understand. Sir, I would like to ask, what is tertiary hyperthyroidism? Lavesh, what is tertiary hyperthyroidism?
Sir, it is the toxic adenoma.
No.
How does it develop?
What do you mean by it? I have no K1
It is the autonomous nodule. And
so how will you how is it different from secondary hyperthyroidism?
Sir, it does not depend on the TSH. In the secondary hyperthyroidism, there is a fluctuation of the TSH level, and ultimately it becomes the nodular.
So you want to say still it is toxic nodule, but dependent upon TSH?
No, sir, it is independent.
So how is it different, secondary and tertiary?
I don't know, sir.
Anyway, you go and read it about it. That tertiary is a very controversial term. It's okay. Secondary can be multinodular, can be unilocular. When the one nodule becomes dominant, other nodule gets suppressed and then becomes the only functioning nodule, and what we call it as a tertiary, whatever it is. Anyway, please, sir. Anybody else would like to ask anything? Apurva?
Yes, sir. So Lavesh, what is the pathophysiology? साहब मुझे पूछिए secondary hyperthyroidism में.
Sir,
what is the pathophysiology of development of multinodular goiter for that?
Yes, sir. Long-standing goiter, there is a fluctuation level of the TSH level, TSH, thyroid stimulating hormone, lead to the some glands in the gland, some follicles become the hyperactive and some become the less active. In the hyperactive, there is a neovascularization, and subsequently there is a hemorrhage, and the central part of necrosis is occur, and the collision of these lobules form as a nodule, and this forms as the nodular goiters.
Okay.
So, Lavesh, what are the chances of in that process the nodule will become malignant? One is it can develop hemorrhage. Do not confuse hemorrhage with the autonomous nodule. Similarly, malignancy can develop. What are the chances? You know the percentage that in a multinodular goiter, one of the nodule may become malignant. And if it becomes, which type of malignancy it is?
Sir, it converts into follicular carcinomas.
Okay. And percentage you feel, because I don't know exactly. If Aditya or anybody can say, that's all right.
I don't know, sir.
Okay. Please continue.
Sir, general examination.
So shall we go to examination, sir?
Yes, yes, please, please. Yes, yes.
Now start
Yes,
your
sir.
examination, Lavesh.
Yes, sir. General examination. I have examined my patient in adequate light, proper exposure, with consent and with presence of female attendant. Patient is conscious, cooperative, and well oriented to time, place, and person. Patient is averagely built and nourished. Temperature is normal. Pulse is 82 per minute with his regular and with normal rhythm and volume. Blood pressure is 110 by 70 millimeter mercury in right brachial artery in the supine position. With no pallor, icterus, clubbing, cyanosis, or generalized lymphadenopathy, eye signs are absent, and no tremors. In the inspection, a single approximately 5 by 4 centimeter size ovoid shape well-defined swelling in the front of neck extending to the left side of the neck approximately 4 centimeter below the symphysis menti and approximately 1 centimeter above the medial edge of the left clavicle. and it medially 1 centimeter right to the midline and laterally behind the sternocleidomastoid, which moves with the deglutition, and lower margin is visible. It does not move with the protrusion of tongue. No other swelling is visible in the neck. Overlying skin is normal, no scar, sinus or dilated veins over the neck, and oral examination is normal, sir.
So, Lavesh, how do you examine the patient? Whether you examine him from the front or behind? Sorry,
Sir, inspection from the front and palpation from the front as well as from the back, sir. From behind, sir.
Okay. So, what technique would you like to do in this patient? Do you need a special technique or it is
Sir,
a
classical method for palpation. And for the palpation of nodules, sir, Cryles method.
how do you define cries? I mean, describe cries.
So apply the thumb, stand in front of the patient with the slightly flex the neck and put the thumb over the nodule and visible nodule and ask the patient to swallow. And with the pulp of the thumb, try to palpate the nodule, sir.
Okay. Sir, Dubasi, sir?
Yes, yes, you can move ahead. Only thing I was saying, I don't interrupt after general examination itself. Do we need to examine the gait of a patient in a patient with thyroid disease?
I don't know, sir.
Can give a lot of information, especially when you talk of history with relation to hypo or hyper. He may not have understood your questions that time, but in simple general examination, do not forget to even examine the gait of a patient. And how will you check for the muscle weakness? General examination.
Sir, for the grading, sir, 1 to 5 grade, I would like to examine, sir.
No, which is a simple test to check for any proximal muscle weakness that the patient may have.
Sir, against the resistance, try to flex the muscle, sir.
Simple thing, you ask him to get up from the squatting position. If he's able to do without support, I think that's the easiest way. In fact, even if he's not able to get up from the chair, that's called as a plumber's sign, which you can be elicited very clearly on the general examination. So do not forget to examine, because many of the times in the history, the patient may not have understood your questions. You can easily confirm it with these simple tests in your general examination. Thank you. Move ahead.
Nina madam is also with us. Madam, aapne kahi inputs? Ma'am, you are muted. Hello. Madam, you are muted. Nina ma'am. We can't hear you. Anyway. Arvind sir, Aditya?
Yes, sir. Pretty much all right going on, sir.
Okay, fine. So we'll go ahead. We'll continue.
You have some video you have? Is
Yes.
that something? Okay, fine. Okay, go ahead.
In palpation, I have palpated the swelling from the front and behind. Temperature is normal over the swelling and no tenderness. A single 5 by 4 centimeter swelling, ovoid shaped swelling present over the thyroid region, mainly in the left side, with the smooth surface, well-defined, regular margin and firm in consistency. Upper margin is 4 centimeter below the symphysis menti and lower margin 1 centimeter above the medial end of the clavicle. Medial margin is 1 centimeter right to the midline and lateral margin behind the sternocleidomastoid. Swelling moves up with deglutition. Swelling is mobile and fixed to skin, and approximately 1 by 1 centimeter mobile palpable lymph node in left upper jugular chain. Trachea is in midline. Bilateral carotid pulsation are palpable in normal position and no palpable thrill over the superior pole. In auscultation, no bruit heard over the superior pole of thyroid. Systemic examination, cardiovascular system, central nervous system, respiratory system, and abdominal examination is normal. Case summary: 30-year-old clinically euthyroid female presented with the 5 by 4 centimeter size, single, non-tender, ovoid, well-defined swelling from the left lobe of the thyroid with the isthmus and smooth surface with the move with the deglutition and without the compressive symptoms with the ipsilateral upper jugular lymphadenopathy for 6 months.
So,
Yeah, you said various methods of palpation. One is the normal method, standing behind. Another one, to palpate each lobe, what is that method you said?
Leis method, sir.
Cryles stand for?
For the check the nodularity.
Nodularity of the isthmus.
Yes.
Okay, using the thumb.
Yes.
How did you look for the position of the trachea?
Sorry, sir.
How did you look for the position of the trachea?
position of the trachea.
With the 3-finger method, sir. First and the third finger is placed over the medial end of the clavicle, and with the middle finger, try to palpate the tracheal rings.
Suppose it's a huge thyroid, you are not able to see this, feel the trachea and the below. What is the next method you look for?
Trails method, sir. Trails method,
No,
and
no.
also from the above.
You can palpate above this swelling.
Yes, sir.
You can look for palpate also the trachea.
Yes.
What sign you said something?
Sir, trail sign.
What is that sign?
If there is a one lobe of the thyroid is enlarged and it pushes the trachea to the other side, overlying the sternocleidomastoid is bulge is present, sir, over that.
What are the things you examined in the neck in palpation?
Sir, I would like to examine the trachea as well as the palpate the rest of the gland with the lymph node. Is there any enlarged lymph node is present or not, sir?
Right.
When will you use Pizello's method? When will you use Pizello's method?
Ma'am, Pizello's method is used when the short neck and the obese patient, sir.
Okay. So what is the disadvantage of it?
Neck is extended, so palpation in the palpation the gland is not properly palpated, sir, ma'am.
If it is a small gland, then it is difficult to palpate, particularly. Okay.
Palpation of the carotids.
Sir,
Where
here,
did you?
so,
The basics only. Where did you palpate? What is the importance of palpate?
yes, carotid pulsation is palpated at the level of the upper border of the thyroid cartilage, anterior at the anterior border of the sternocleidomastoid, sir, against the C6 transverse process.
What is the importance of?
Yes, continue, sir.
What is the importance of palpating?
If there is a benign enlargement of the thyroid, there is a benign goiter, then there is a displacement of the carotid pulsation posteriorly, and if there is a malignant, then carotid pulsation are not palpable.
Not all malignancy will produce impalpable carotids.
Yes, sir. Anaplastic goiter.
Only when the carotid sheath is infiltrated, yes, you may not be able to palpate, or it may be feeble.
Yes.
To know whether it is completely engulfed or ring, how will you know? You're not able to palpate the carotids.
Yes, sir.
How do you know the carotid is totally engulfed or not?
Yes.
You have to palpate the superficial temporal artery.
Yes.
Okay. So what is that Berry sign?
If there is a malignancy, if there is a
feeble carotids are called.
Yes, sir. Due to the engagement of the malignant cell.
Which carotid you palpate?
Common carotid, sir.
Common carotid. By.
See, when you have the lymph
where does the carotid bifurcate?
Sir, above the C6 level, sir.
Above C. So you are palpating at C6. So it is common carotid. Yes. Okay. Right.
Sir, Dubasi sir, you were saying something, sir?
Yeah. See, when you mention about lymphadenopathy, the moment you have a lymph node palpable, you told the size, but you would like to know the consistency of the node. You would like to know whether it is tender or non-tender.
Sir, it is non-tender and firm in consistency, sir.
Okay.
Size?
Please not forget to mention
1 by 1 centimeter in size.
Yeah.
No, the important thing is it significant, Dr. Lavesh?
Sir, here only the single lymph node is palpable with firm inconsistency. If there is a multiple lymph node along the jugular chain with the there is a hard lymph node, that is more suggestive of the malignancy.
No, so in this case, why don't you commit? Is it significant or not?
Sir, it is a single node with the firm inconsistency. I'm not able to palpate the other node, sir. It might be a malignant due to the malignancy, or might be some other reason, sir.
How many lymph nodes are generally there in the neck?
More than 120. I don't know, sir.
The more than 300, or it could vary anywhere upwards of that. And based on the size criteria, is there anything to sort of suggest it is a significant lymph node?
I don't know, sir. Size of the.
So because every individual, so as I said, there are 300, generally 300 plus about lymph nodes are there, not, and some of them can be enlarged. So the thing here is, again, just as you are looking as to whether a solitary nodule is malignant or not, here our aim is to see whether your lymph node can potentially harbor malignant cells, right? In this case or any other case of the head and neck. So there are some size criteria described. They may not be absolute, like no, it is not, but generally around more than a centimeter in in all levels, except in levels 2, wherein you could have an enlargement of more than a centimeter and a half. So this is a rough sort of algorithm given, but it could but again, like sub-centimeter nodes also can harbor malignancies. They can also have extranodal extension. So all those caveats are there, but generally, if you call a significant node, at least from the size criteria, it should be more than a centimeter or a centimeter and a half in the level 2 region, and it has to be firm to hard. So only then in your clinical examination, possibly you can call them as significant. But based on your thing, I'm not really sure. This was at what level? Level 2, you're saying, no?
Yes, sir.
Yeah. So based on this criteria, it cannot be called as a significant node. You can mention it, but see, at the end of the day, you'll have to stick your neck out at some point of time to sort of say whether it's significant or not, because it may have an implication on your clinical staging. So whether you are going to stage, if at all you think it's a malignancy, and we have not come to that also. So in that case, you'll have to stick your neck out at that particular point of time. So all those things, to substantiate your finding, all these things would be important at that particular point of time. Yeah.
Yes.
So, but as was rightly said, whenever you are mentioning about lymphadenopathy, you must mention all the important aspects of it. And you did to some extent, but you'll have to sort of give the context also. Like you think it is significant, it sorts of tells the examiner what is running in your mind.
Yes.
Yeah, that's all from my side for now.
Yeah. So, can you describe what is this upper jugular? So, I mean, basically the levels of the neck that you would care to say. Well, what are the levels of the neck that you would look for anatomically? You have said here upper. So, what would qualify as upper, and then maybe what is middle and what is lower jugular lymphadenopathy?
Yes, sir. Upper jugular lymphadenopathy, it is level 2 above the bifurcation of trachea, sir. Or sorry, above the bifurcation of carotid. And level 3 from the bifurcation of the carotid to the level of omohyoid, posteriorly of omohyoid, and level 3 from the omohyoid to the clavicle.
Omohyoid to the clavicle. Yeah, so broadly that may be right. We generally classified using some sort of a bony or a cartilaginous structure. So it usually from skull base to hyoid, hyoid to cricoid, and from then cricoid to clavicle. That is generally how we classify the levels of the jugular with reference to the jugular. You may be right with regards to the levels, so that is true. But that is how we generate it. Yeah, please go ahead.
I agree. In terms of clinical examination, bony landmarks are something that you can feel.
Right,
But
sir.
crossing of the omohyoid and all those things, it will be almost impossible for somebody to sort of clinically make out. So but you're right, Lavi, there is a sort of a classification of the lymph nodes based on this anatomical classification itself. But from the clinical context, it is very easy to feel the thyroid cartilage upper border and the cricoid, right? So I think in those terms, if you tell, it is also acceptable. And the other thing is, who classified the neck nodal stations that you are saying?
Right on, sir.
It's a older classification, the AHNS, American Society of Head and Neck Surgery. 1991, there was the classification. It's a long history to it. Then subsequently, it got modified over the years. 2007 also, there was addition of level 6, level 7. So all these things, it's a remarkable history of how the lymph nodes came into existence, the classifications, the boundaries. But it is important for you all to have a understanding, at least based on clinical bony landmarks. And of course, your carotid bifurcation omohyoid is also a reasonable surrogate to these bony landmarks.
Sir, that is why we have all of you stalwarts here. Basically, see, you never know where the exam goes. I mean, in his capacity, an examiner has all the right to ask him anything and everything, including history part.
Right.
So nothing wrong in it. Absolutely right, sir.
Some examiners like history, no? So, and
Yes, sir,
especially
yes,
if
anecdotal, definitely. Definitely. The more senior, the more anecdotal.
Absolutely.
But that is part and parcel of the training program. So nothing wrong in it, sir. He should know he should definitely know that part. That is for sure.
Right.
And
No, it's knowing is one thing. It's a fascinating read also, no? That is also another. Yeah, go ahead, Dr.
I
Lavesh.
think if we may take a small detour here, Lavesh, did you mention about the swelling moving with the protrusion of tongue, and if the respected seniors would like to ask about the implications of that?
The
Srinivasa
swelling,
sir, Dubhashi sir. So why does it occur, Lavesh?
Yeah,
yes,
tell
sir.
me.
If
Two
there is
things,
a
two parts. One is why does it move with deglutition, and second is what about protrusion of tongue? Two things separately.
thyroid swelling move with deglutition because it is encapsulated with the pretracheal fascia, sir. And posteriorly, condensation of the pretracheal fascia forms the Barry's ligament, and it attaches to the cricoid membrane, and it is attached to the inferior constrictor. So while deglutition, the thyroid swelling moves, sir. With the protrusion of the
Yeah,
tongue.
so apart from these two, what you told, especially with reference to this attachment and that ligament of Berry, that's the posterior aspect of the pretracheal fascia. Is there any other reason why thyroid gland moves with deglutition? Then we go on to protrusion of tongue.
It is covered by the pretracheal fascia, and pretracheal fascia superiorly it attached to the base of skull, and inferiorly it frees.
So apart from that, also it is in relation to sometimes you have an additional pyramidal lobe which is in relation to the isthmus of the gland. You want to elaborate a little bit on that? Can that contribute to the movement on deglutition?
So there is a lingually thyroid attached to
Levator glanduli thyroid. Yes, that's the fibromuscular band from the pyramidal lobe to the
hyoid bones.
Okay, fine. Yeah. Now move on to the protrusion of the tongue movement.
How many fascias are there in the neck?
Sorry, sir.
How many fascia are there in the neck?
Sir, investing layer of the deep cervical fascia, prevertebral fascia, and pretracheal fascia.
So which is the one which covers thyroid? It is
Pretracheal fascias.
So generally, when you are asked this question, you go from front to back or back to front. No, so if you tell this one, no, then I think so. It's always preferable. You're right. I mean, your answers are all right, but then try to follow a systematic, either from the front to the prevertebral or from prevertebral to front. So that may tell your examiner, no, that you are systematically following a pattern of 1, 2, 3. But your answers are right.
The way of answering, that's what I asked you. So it encircles the gland, condenses posterolaterally, forms the Berry's ligament, which gets attached to the cricoid cartilage. And how does that move up?
It attached to the inferior constrictor muscle while deglutition.
Not attached. What are the inferior constrictors?
Thyropharyngeus and cricopharyngeus.
Cricopharyngeus and
Pharyngeus muscle.
Right. Do they take origin or they get attached?
Attached.
So from there, what happens? Why? So during swallowing, the phase of deglutition, this get contracted. That is the only muscle which pulls up the cricoid cartilage. When it pulls up the cricoid cartilage, the gland also moves up. Can you name some other swellings which move with deglutition?
Sorry, sir, other swellings?
Some other.
Sir,
What are the other swellings?
Subhyoid bursa, pretracheal or prelaryngeal lymph nodes are also moves with deglutition. Thyroglossal cyst also move with deglutition.
What is the peculiarity of thyroglossal?
It also moves with the protrusion of tongue.
Why?
Because if there is a remnant of the thyroglossal tract, it attaches to the base of cecum at the tongue, sir.
What type of cyst is
It is a
thyroglossal?
tubulodermoid.
Very good, very good. Okay.
Okay, go
Yeah,
ahead.
you were on to that protrusion of tongue, movement of protrusion of tongue.
And you said you auscultated on the superior pole of the thyroid. Why?
Sir, there is superior thyroid artery which supplies the majority of the thyroid gland. It is more superficial at the superior pole of thyroid, sir.
Superior thyroid. It's a branch of the
External carotid artery.
What is the peculiarity of that one? That is the only branch of the external carotid which descends. All other ascends.
Ascends, yes.
Okay. Once it enters, the gland divides into two.
Anterior and posterior.
Right. So that is why you are able to listen in the upper pole.
Yes.
You said that the lower pole is visible. Why? When it moves, you say moves with deglutition is a good answer. Don't say moves up, because all glands moves up only. So moves with deglutition is one. Now, you said lower pole is visible.
It will get idea about this if there is a retrosternal extension is present or not.
What are the types of retrosternal goiter, you know?
It is intrathoracic, plunging, or substernal type.
Substernal, plunging, or intrathoracic. How do you classify retrosternal goiter?
If there is a totally, if some part of the gland is visible.
Primary or secondary?
Yes, sir. Primary, secondary. Secondary is due to the enlargement of the goiter, and part extend beyond the.
Proceed. Sir, anybody else, please?
Yeah, please.
Yes,
sir.
No, go ahead, sir. I'll ask later.
Fine. So I think we can go up to differential.
Yes, sir.
So Lavish?
Yes, sir. So my provisional diagnosis is euthyroid solitary thyroid nodule in left lobe and isthmus, sir.
Now this is not a diagnosis. This is a functional diagnosis. See, this is escapism. See, Dr. Arvind, what did he say? That when you have to put your foot in. Right or wrong is a secondary thing.
Yes, sir.
Or why you think about it in that particular way is very important.
Yes.
So this is not a diagnosis. What is a diagnosis? Maybe differential 1, 2, 3, but that should be it.
Yes, it might be a benign thyroid, benign adenoma, or might be a colloid nodule, might be a early malignancy.
Aditya, all smiles.
So, I mean, the thing is, again, when Lavesh, you said that you are including all the conditions, it shows that you may not be fairly certain about your diagnosis at this moment. So maybe you could construct a history in a manner where it is a little bit more pointing. From what it looks like, your description suggests that it's a colloid nodule in the left lobe of thyroid, which is more likely to be a goiter. So or a nodule is what you are saying. So if that is the case, you be more specific with regards to that, and you can always justify it later. See, we are not arriving at a final diagnosis here. Obviously, you'll need investigations and all. But as you said that it's a firm swelling. Could it be an early malignancy? Yes, of course it could be. But your first provisional diagnosis is what? That is what we are looking for here. So now with that knowledge, tell me again, what would be your first provisional diagnosis? We'll include the DDs at a later point.
It should always be 1, 2, and 3.
Yeah.
So my first provisional diagnosis, it might be a early malignancy, and second, it might be a colloid nodule. and also it might be a benign adenoma, sir.
I think you are in soup. But anyways, why do put the first as malignancy? Tell me.
Sir, younger age, shorter history, and lymph node is palpable, sir. Uh, Otherwise,
What are the other features which would we suspect malignancy in a nodule clinically? Just whatever you have told, will that suffice? Anything more than that?
Sir is asking, please pick out the points from your history and
Just
examination.
enumerate all the points that would suspect a malignancy in a
Malignancy.
nodule. Correct.
sir, younger the age group, then it might be if there is pressure symptoms is there.
So this
If there
patient
is
has got pressure symptoms.
Yeah,
no,
sorry,
sir.
sir. Lavesh, this is, Dr. Dubash is asking, pick out the points in your history which are suggestive of that you have put it number one as malignancy. One you said is young age group. We all agree. Second,
Shorter the history, sir.
So there are no pressure symptoms, right, in this patient.
No,
Yeah.
sir.
Next one.
Shorter the history, sir. 6 months.
Hmm.
And lymph node is palpable.
It's not about just a shorter history. It's about, is there any rapid increase in the size of the swelling? That's what we need to look into. Is there any
Yes.
history like that?
No, sir.
No, sir. Okay. Next point.
Sir, lymph node is palpable in the upper jugular chain, sir.
Again, there was a very significant lymphadenopathy just a few minutes ago. So was it a significant one?
No, sir.
No, sir. Next point. What was the consistency of the swelling?
Sir, this is firm.
Firm consistency. Okay. Is there any evidence of any fixity?
No, sir.
No, sir. So after all this, so why it's all coming to malignancy as the first one? So that again brings us back to that. Now you justify.
Also, I think if I may add to Sir's point, the age factor that you said first, that is a very, it could be a misleading thing because this is a woman in the early 30s. I mean, 30-year-old is what we are looking at.
Yes, yes.
Yeah, Arvind sir told, and all other sirs have also agreed that we are looking at extremes of ages. So a 30-year-old very much falls in a low risk category, even if it's a thyroid cancer. So just because it may be a 30-year-old woman, is not the first thing we would be mentioning with regards to when we are calling it to be a malignant thing. I guess that is what sir also wanted to say.
Yeah, in short, no, Dr. Lavesh, you may be right. Finally, this could be malignant also, essentially. But then, what the examiners are generally seeing is what is your thought process, essentially. And in this case, it's pretty difficult, because it doesn't really fit into a lot of the malignant factors. Barring the lymph node, what you say, the history is, say, plus minus, essentially, So I guess, it's a difficult call, basically. A solitary thyroid nodule, you should, in such cases, when it's a difficult, tricky call, you can say that I would like to give a differential diagnosis, and then possibly ask the examiners to sort of rule in or tell points substantiating a diagnosis, one diagnosis over the other. Maybe that's. But I guess, since you said your provisional was malignancy first, I guess that is why the volley of questions, why malignancy comes out, essentially. I agree, if it was firm to hard, if the node was significant, then you sort of push for or infiltration into surrounding structures. With none of them being there, that is why the pattern of questioning is going in that direction. So you can possibly, in such a case, maybe put it as a solitary nodule, a dominant of a multinodular goiter first, and then possibly say that cancer, because as I initially said, that the most common presentation of a cancer is a painless swelling, exactly in this form, essentially. So other factors like lymph nodal metastasis, fixity, and all are telltale signs that this could these are the chances are higher that it could be an advanced cancers. But whether it's an early cancer is something that we would never know out unless we investigate, as Aditya also said. Yeah.
And also just a tactical thing that if you are planning to put malignancy as your first diagnosis, then during your examination, you should dwell on the specifics of the lymphadenopathy more. That might help you in justifying your putting the malignancy part as the first, because while we were listening to the case summary part or the examination part, there was just a fleeting mention of some lymphadenopathies. If you want to really put it as the first diagnosis, then dwell more on it and construct it in a way that it sticks out as a particular thing, because none of the other features are directly pointing it as a malignancy, so that then putting it as the first, as sir said, may not be a wise strategy to do.
Yes.
And you have to be you have to get your clinical findings right, just to sort of substantiate your malignancy. Don't put it as a larger swelling or a harder swelling or something of that sort. That I guess a lot of examiners would take a lot of offense. If you don't get your clinical, so get your clinical findings bang right, and then maybe substantiate one way or the other.
If you say malignancy as the first one, the examiner will think that you have seen the histopathological report and come. So, as a postgraduate MS examiner, we expect you to answer. One is usually a solitary thyroid nodule. I expect is a prominent nodule of a multinodular goiter. We have not seen the other. Clinically, we are not able to palpate, but during ultrasound. Second, you bring it as a benign one. Third, you bring it as a malignancy.
I agree.
If you say malignancy, the examiners will definitely think that you have the histopathological report with you. Definitely.
No, again, as I said, no, you had it all right. It is just the order of your sort of how you are able to sort of
And this is not classical
order of your
findings of.
differential diagnosis. I think
This is
he's
not
doing well essentially. I think
Yeah, you're doing.
in terms of all the points, I think I'm quite impressed
There are
by
no
his
classical
approach.
findings of a malignancy.
Yeah,
You say malignancy means you have the histopathological report with you.
Or your super has told you what case it is. So, I mean, yeah, I agree. The lymphadenopathy, you cannot see. There are two important things. If there is a lymph node, you need to tell the lymph node, even if you feel that that is going to be a hotspot, because these are all clinical things. Any examiner would stand and palpate the neck, and then you will be in a problem. So you have to say that there is a lymph node, but because it's a 1 by 1 centimeter lymph node, may or may not be malignant, as Dr. Arvind already said. But furthermore, if you want to go into details, that how would you like to investigate? Arvind sir, please. Lavesh, how would you like to investigate this patient? You have to reach to a diagnosis and give him some treatment.
Yes, I would like to investigate first the thyroid TSH level. Then, according to the TSH level, after that USG NAC, and then if there is a USG NAC according to thyroid staging, I would like to go for further FNAC, sir.
So one thing. First of all, you said first thyroid profile or TSH and then sonography, and then I agree. But then, is there anything related to this your thyroid TSH and sonography? Some relation? I mean, what would you say? Supposing T3 is high or T4 is high, you would like to go for something else or something? Just asking.
Sir, if TSH is low, and then suspecting toxic adenoma, I would like to go for the radioactive iodine scan. If if there is a hot nodule, there is chances of toxic adenoma or the secondary thyrotoxicosis is high, sir.
Right. You have the investigations?
Yes, sir.
Just one thing. You said hyperthyroid. Supposing, so in 6 months, okay. What are the different phases that you find upward? Because one of your diagnoses was thyroiditis also. Of course, patient did not have any pain. So, is there any chance that the patient may be hyperthyroid previously or not now, or he is hyperthyroid now and may after 6 months may be euthyroid or something?
Might be Hashimoto thyroiditis.
So how do you differentiate? Why did you stick directly to radio immunoassay?
If the TSH is low and T3, T4 is high, that is, if there is low TSH, then radioactive immunoassay is.
So, okay, so what is the pathophysiology of hyperthyroidism in Hashimoto's?
In Hashimoto thyroiditis, it is antibody-mediated destruction of the follicles and release of the thyroid hormones.
So what should be the picture if you take radioimmunoassay in
In radioactive scan, there is a decreased uptake.
Okay, fine. Okay. So first is to go for thyroid profile just for the sake of it. That of course you have said that clinically the patient, the patient is euthyroid. Otherwise, baseline parameters are required before you do any other manipulation with thyroid gland, so as to get the proper readings of the thyroid profile. Right.
Yes.
So you go for thyroid profile first, followed by ultrasound. Now, what likely is the pictures of ultrasound? What are your options, and what are your how will you go? See, ultrasound is very important. That will give you idea of which way you want to go.
Yes.
So, what ultrasound do you think this patient will have, or
Sir,
if the patient really has an ultrasound, you
yes,
can
sir.
always do that.
Yes, sir. In this patient, this patient reports are approximately 3 by 4 by 4
Do
centimeter
you have
size.
you uploaded the slide of report?
Sorry, sir.
Have you uploaded the report on the slide?
Sir, USG is uploaded, sir.
हाँ तो बताओ ना.
Yes, sir. देखा है?
देखे
Sir,
Yes, we are seeing it. We are seeing it. Yes.
Yes.
Read it.
It is a 3 by 4 by 4.7 centimeter size, solid, hypoechoic, wider than taller, smooth margin, and peripheral enhancement, query calcification, lesion noted involving the left lobe of the thyroid gland, and above finding suggestive of thyroid 4 lesion, and FNSC correlation further is required. Presence of the few tiny spongiform lesion is noted involving the right lobe of the thyroid gland, and the presence of few subcentimetric size lymph node in level 2 and level 3.
Sir, Arvind sir, Aditya sir.
Yeah. So I think your level 2 node is taken care of now here in the ultrasound. Assuming your ultrasound is correct, essentially. And so anyway, that is the thing. Yeah, I think it's good. Like, one thing I would like to say is that, it is good that all sonologists are reporting thyroids, and I guess in case sonologists are not reporting, it is the duty of the surgeons to sort of tell the sonologists to sort of report all ultrasound in the thyroids. So that's becoming universally accept the practice in many parts of the country, and I'm happy to see that, and I'm also happy to see your report also, your radiologist also mentioning the thyroids thing.
So what, Lavesh, what would be the features that would point towards a malignancy? And if you could care to explain some of the terms here, like what is wider
Yes.
than taller? Yeah, so tell me
Sir,
what.
Sir, there are some features like composition, shape, margin, echogenicity, and echogenic foci. There should be included in thyroid staging, sir.
Okay. So what is wider than taller here? What does that mean? Because that's an important characteristic that is used in all reportings these days. So what does wider than taller mean actually?
So, it is in the sonography, the lesion, it in the shape, it is sir wider in the transverse direction than the sorry, sir, in the according to the probe, sir.
Yeah. So tell me. Right.
It
So
is deeper in invasions.
So basically, as you know, the sonographic probe sees the cross section of the thyroid gland, right? So anything that is wider is more on a surface level, right? It's on the surface; it has not penetrated deep. Whereas a taller thing will be seen on a. You should see some of the ultrasound scans or the reports that are there. A taller is supposedly more penetrating in the substance, inside the substance, not like this, but actually like this. So that is why a taller than wider composition in the thyroid is an important characteristic that could lead to us believing that the substance of thyroid has been infiltrated more by a particularly solid tumor. So that would mean that there is a possibility of malignancy. Now, this here is obviously wider than taller. So this is telling us that it is more on the surface and not going deep that way. So it is one of the features. I'm not saying that's the only feature that would be important, but yeah, so that is the thing. Yeah, all other sirs.
No, the Thyroids is something that, of course, it can come as a short note also, or maybe a focus, may not be for you, but at least for the higher people. But it is important to understand what is the importance of reporting in a Thyroids?
Sir, it will give idea about the is there is a chances of malignancy.
Correct. Risk of malignancy. Okay. So in Thyroids, 4 is, I mean, if you want to take it to a higher level, it's divided into A, B, C. So I think if it is there, then you can ask your sonologist based on how many suspicious features are there. Essentially, they will report it as a Thyroids A, B, C, and more the features, more the risk of malignancy would be there essentially. So it's something that you all can read. It's easily downloadable. The other thing that you need to know is what Thyroids they are falling, because there are multiple associations that have actually reported Thyroids. This is called ACR, American College of Radiology, is a classical is the first association. 2008 or 9 they reported it, and then subsequently there have been a little bit of modifications. Many other agencies have also come up there with their own Thyroid scoring, but generally what is followed globally and what is more popular is the ACR Thyroids. So generally when you are sort of you tell them ACR Thyroid. Like for example, in BIRADS also, no? If you tell what BIRAD, what is the organization or association that is endorsing this view, that means you have known a little bit of how it came to existence. Yeah. So that's the importance of this essentially. You have an FNA?
Yes, sir.
Finally,
it is suggestive of papillary thyroid carcinomas.
Yeah, see, finally you've been proven to be right, I think. Huh?
Or maybe, sir, this was the report which inspired him to be right.
Yes,
Yeah, but on the lighter
Your
note,
diagnosis is correct, but based on this, you cannot say in the exam. Please.
Correct.
And in our exam, don't go with this one. Go with the clinical findings, then sort it out, then say.
Yes.
But you have done it very good.
Never undermine your clinical acumen. See,
Yeah.
because that is what really speaks in the exams.
Yes.
What is this TBS category 5? What is this terminology?
Sir, it is the sir, it is the classification, sir, category 5.
What classification are we talking
Thyroid,
about?
Thigh
No.
5. It
What
is
is
the
the accepted?
Bethesda, sir. It is
Yeah, exactly. So you're talking of the
Bethesda
Bethesda system for the reporting the thyroid cytopathology, right?
Yes, sir.
Yeah. So what are the diagnostic categories as per the Bethesda system?
Sir, it is here category 5, sir. Suspicious of malignancies.
What are the first 4 categories then?
Sir, 1 is non-diagnostic, 2 is benign, 3 is FLUS, follicular lesion of unknown significance, 4 is FN, follicular neoplasm, 5 is suspicious of malignancy, and 6 is there is malignancy.
Yes, sir. We talk of benign, we're talking of the benign nodule, we're talking of even the Hashimoto's or even the subacute thyroiditis that we are talking about. Yeah, that's right. So remember the Bethesda system for reporting the thyroid cytopathology. That's fine.
And it's important that you study this Bethesda system because again, Bethesda 5 makes it pretty clear, yes, in this particular case, but there will be instances where you will be asked about what is to be done in Bethesda 3 and 4. So you should have some clarity about what is there. So going forward, I think we will discuss that, but for now, I think you can go ahead. Unless any sir.
What is Bethesda?
It is the category according to the FNSE report,
No,
sir.
that I know, but is it a person, place, thing?
The word represents what?
It is, I think, a place in USA.
Right. And what all the Bethesda, there are multiple classifications of Bethesda classification. Can you name any other classification in the body which has a Bethesda classification?
Classification is the name of Bethesda.
I don't know.
Because like like all our examiners like Pagets a lot, across the body you'll have some a lot of Pagets, like so that is sort of very very lot of seasoned examiners like to ask about Pagets like that. So a lot of seasoned people who are more into these classifications now may ask you about what all are Bethesda class systems of classifications across the
All states and cockers of the world.
Yeah,
Yeah.
Bhag
Cockers
Chet, yes.
also, yes. Season like to ask about cockers also, not pirates. Yeah.
Yeah, correct. Welcome.
Okay. So going ahead, sir, we'll go towards his intention of treating the patient.
Yeah,
Yes,
quickly,
yes.
and we can wind it up.
Then answer that, sir. Bethesda, what is Bethesda?
Krishna?
Arvind, sir. What is
Sir?
Bethesda? One more.
No, there was a cervical classification also based on Bethesda also.
Okay, sir. Okay.
For cervix. Thyroid and cervix classifications.
Okay, sir.
Yeah, the treatment. Yeah,
The
treatment outline.
LSIL, HICL and all. So yeah, in this case, you can quickly sort of go ahead, because for the treatment, it will take a long time. But yeah, I guess you can. In this case, it is pretty straightforward, I guess, the
Yes, sir.
management.
So Lavesh, what do you plan for this patient?
Sir, I would like to go for the total thyroidectomy with
Right.
the if there is with the central and central lymph node dissection and modified radical lymph node dissections.
Calm down. So, I mean, would you like any other imaging before you proceed for
Yes,
your?
sir. I would like to go for CT scan as for the status of lymph node.
Go ahead. What else? What else would you like to see on a CT scan?
Sir, other lymph node involvements, and there is a sir, if there is a extra thyroid invasion is present or not.
What area would you like to cover in your CT scan?
Sir, neck and the upper chest.
Just upper chest. And why would you want to see the upper chest?
Sir, for the retrosternal lymph node and also the mediastinal lymph node, I would like to see for the chest.
So now that you have established that it's a cancer, right? And it's a 4.5 by 4 centimeter cancer that we are looking at with a potential lymphadenopathy, although sonography hasn't told us. So why would you, I mean, I would include the entire chest alongside so that at least I would know the status of a potential metastatic lesion in the lung. So I think you should be more specific in saying a contrast enhanced CT scan of the neck, which includes thorax. I think that would be a more specific way of going ahead with this particular thing. I think there are also concerns that you may be asked about, okay, would you use a contrast in this or not? So what is your take on that? It's an iodinated contrast. So would you use it for scanning or not?
So previously, it is called that is NCCT is preferred, but nowadays water soluble contrast is available. So CCT contrast enhanced CT scan is preferred, sir.
And why are those concerns even a point of discussion? Tell me, why are these
In
things?
future, patient requires the radioactive iodine therapy, then uptake of the iodine will be affected if there is a previously thyroid gland uptakes the iodines.
Mhm. So these things wash out in how many days, the water soluble contrast?
3 to 4 days.
Okay, go ahead. Yeah, so now we have done the CT scan. I think that is, sir, I think Srinivasan sir wanted to say something.
No, why not a hemithyroidism?
Sir,
What are the? No, I'm just asking you. Can you do hemi? If so, what are the indications?
sir,
Not
hemithyroidectomy can be done if there is a low risk factor less than 1 centimeter in size of the cancer in the papillary thyroid cancer with the unifocal involvement and no extra thyroid spread is there, and with the less than 5 lymph nodes are involvement.
So all your findings fit here, isn't it?
Sir, it is more than 4 centimeter in size, sir.
It's more than 4 centimeter.
So I would like to.
Only that is the only thing contraindication.
Yes, sir.
Also, and
The
what
oncologist does what you do, sir? Will you do an chemi?
No, sir.
we want to do a total, but we would be, I think, less radical than Lavesh would be in terms of addressing the neck.
Correct. Yeah. The other point is regarding CT scan. There were two schools of thought essentially. Like earlier, the classical teaching is, and then of course the ATA, the American Thyroid Association guideline is now 2015 old. Right? It is there. So now we are due for another a newer version of ATA. I think it is expected sometime this year. Things may be things may change. A lot of things may change in the latest ATA classification that comes. But if you see in that ATA, they've said that you do a cross-sectional imaging, either a CT or MRI, only when it was, say, locally advanced fixed or something like that. So that is a classical teaching. But of course, right, as Aditya also said, now a lot of perceptions are changing, because in this case, the swelling in the video also you demonstrated is quite mobile, moving with the thyroid gland. So a lot of examiners or a lot of senior people may sort of stick to the ATA older guideline and say that you don't need to do a CT scan. In which case also you'll have to be a little. That is also a reasonable approach that was practiced. But nowadays, what happens is, as Aditya said, a lot more of the thyroid surgeon centers now, in some of these larger nodules, they tend to do CT scans also essentially. So you must know exactly what is the guideline saying and what is the real world practice. There may be some little differences. And here you're right with regards to the extent, because you yourself clinically in your examination said that the lymph node is just 1 into 1 centimeters barely sort of, and then the ultrasound also. Then why do you sort of want to chase that? I mean, doing a central compartment deck dissection, of course, it may be reasonable in your case, but to do a lateral neck dissection is something more of an overkill, at least based on assuming that your CT also does not show any significant nodes. I think that would be a reasonable way to go about based on your clinical findings and the radiology of the sonography that you put up.
What is central compartment essentially, as you would define intraoperatively? Maybe you are saying that you want to clear it. So, what are the anatomical boundaries of the central compartment that you would look for?
Superiorly up to the hyoid bone, laterally to the carotid, and inferior margin up to the subclavian arteries.
Subclavian artery. Okay,
Subclavian, huh?
Yes.
Comes here. Where does the subclavian comes?
Sir, it is behind the manubrium.
Subclavian comes there, or
Brachios
the innominate
brachiocephalic.
brachiocephalic crossing will be there.
Brachiocephalic. Sorry.
Yeah.
Yes.
So the innominate, subclavian is coming a little bit laterally, right?
And so if you are
We'll have the. Yeah, go ahead.
no, sir, please. Yeah. So if you have to define it, that would be level 6. What is level 7 in the modern context?
Mediastinal group of lymph nodes.
Right. So I guess we can all agree with total thyroidectomy, right? That is what we are planning to do. What are the indications of central compartment node dissection in a case of this thyroid cancer without any other high risk features? So what are the indications of central compartment node dissection? And what are the morbidities that are associated with central compartment nodal dissection?
In the papillary thyroid cancer, if there is a lymph node, central compartment of lymph node are involved, then central compartment lymph node dissection are done. Is done.
Okay.
In
Other than that, supposing your ultrasound is not showing, ultrasound or CT is not showing central compartment nodal enlargement, would you proceed for central compartment? Because you said no, in this case it is not showing any nodes, but you would still want to go for a central compartment node dissection. So why would you do that in this case? And if not in this case, then in what other cases? Chalo, you said one is positive nodes. That's fair. Other cases,
if the lateral compartment of lymph nodes are involved, then central lymph node dissection is done, sir.
the fair left field, but fair. Yeah. Okay. Others? Extrathyroidal extension.
Yes, sir. In the T4 stage, T3B and T4. extrathyroidal extension is there.
Okay, so what are the stages of extrathyroidal extension that we are seeing? Can you define as per the latest AJCC guidelines?
Sir, for the extrathyroid invasion, T4A, T4B. T4A, it involves the skin, platysma, trachea, esophagus, and recurrent laryngeal nerve. And T4B, it involves the carotid sheath and prevertebral fascia and mediastinal vessels.
Arvind sir.
So no, according to your thing, then why are you wanting to do a central compartment? You said, what did you say for central compartment? If there are positive nodes, this case you don't know, or you, at least radiology, clinical radiology, you don't know. Presence of lateral neck nodes, you said. Lateral neck nodes are sort of not there. I mean, they're insignificant. The other thing you said, T4. So in your diagnosis, nothing of that sort is there, and yet you want to sort of say that you want to do a central compartment. Actually, you also committed to a lateral neck dissection also. Why do you want to do a, say, leave aside lateral, which is probably an overkill, to come to the central compartment? Why do you want to do? Because whatever your three criteria that you said, it's not fitting into what you said, right?
So it is more than 4 centimeter in size.
So then you want to rephrase then
So
your answer. Because Aditya asked you, when do you do a central compartment? You gave three answers. T4, positive central neck, and lateral neck positivity. So it will be what? To complete your answer, it will be a T3 or a T4.
yes, T3.
Okay.
Yes.
So then we'll possibly sort of, consider to do a central compartment dissection.
Yes.
Also, Lavesh, there is one factual thing that we cannot ignore here. The AJCC that I asked, you were right about T4 and T4B, but the latest AJCC, that is 8, which has been in vogue for the last 5 years, has specifically included only strap muscles involvement
T3B.
as T3B. Yes, so it's not just T4 and T4B, it has to include T3B also, right? So when you are asked about extrathyroidal, include T3B also alongside it, because it's a factual thing, so there are no gray areas in that, so you'll have to be specific with
Correct.
regards to that, right? So that is the thing. I think any of the senior sirs would like any comments on.
Just one thing I want to say, as what Dr. Arvind already said, that the thing is that because you know central node compartment dissection or probably knowledge of your central node, you don't say that you are doing a central node dissection. See, that creates a bad impression in the mind of the examiner. Ultimately, it is the examiner. See, you are right or wrong comes second. The first thing is you have to impress upon the examiner that this is the way this is going and this should be like this.
Right.
Ultimately, what has happened is you have fallen. See, Arvind sir is really very humble. I mean, he caught you in your own trap, and still he is saying everything is fine. In exam, you would have failed at that stage. Agatya, the important part is don't undermine the clinical things and always be bold enough to say what is correct and what is real. See, don't go for theoretical things. They can always ask, "Okay, bhaiya, lymph node che to won't you like to do anything for the lymph node?" Then you can say that, sir, it's a small lymph node or it's a large lymph node. You want to do or you don't do. That's a point of discussion later on. The baseline should be like this.
Yes.
Plus, this is important because this is your crux of your entire case, because the how you are managing this with regards to the management as well as the neck dissection will determine your clarity of thoughts. And I'm sure the sirs who are taking exams all over the years have seen many different cases where the candidates are trapped in exact this thing, where they start off saying something and then the management goes to some other track, so this management is fairly straightforward. There are no, like, you may be having a doubt with regards to whether it's a hemi or a total in a small thyroid cancer or not, but in these type of cases the management, there's only single way that you are managing this particular case. So we have to be very specific, as Apurva sir also said. It's very important to be specific with regards to that. Yeah.
And your main aim is to convince the examiner that this is right, what you are doing is right. It has nothing to do with what is written in the books.
Agree.
But anyway, to be fair, I think this clinical examination was good. He answered a lot of the relevant questions that were there, and some of these questions that I asked was because he was answering well. We had to slightly raise the bar. That is the only thing. Like, but otherwise, I think by and large, I think from what I see is that majority of the answers that he gave very well, essentially.
Sir, we try to cover almost everything in this session so that if, and most of the students, they say that at the end of the exams and all those things, they try and see all these videos so that there are no questions unanswered. So basically, last time we had a case of CA breast, where we had a medical oncologist as well as radiotherapist with us.
Fantastic, sir. I think.
So what we try is, and sir, this is ultimately is a mock drill. Ultimately, he has to go and show that drill somewhere else.
True, sir.
And already we discussed that there are so many things that can be asked. So he may have done fine. That is not the thing, but we try and cover up everything that is possible. Sir, any points from your side, Aditya, sir, Arvind, sir, to be added?
Sir, kindly brief about the post-operative follow-up.
Oh yeah, perfect.
Sir, after
Malignancy, 30-year-old. He has
So
done
you have done
a
you have done a total thyroidectomy. We have all said yes, okay to that. Now, how will you proceed with the patient?
post-operative follow-up.
Sir, I would like to follow up with the thyroglobulin, anti-thyroglobulin, and TSH level. With the in first 2 year, every 3 monthly, 3 to 5 year, every 6 monthly, and after the 5 year, every 1 year, sir, annually.
Okay.
I think this may be that you are absolutely right. Next level question would be, what is a stimulated thyroglobulin test? Do you know? Are you aware of that?
Sir, it is stimulated by the I think it is yes, sir, decreases for the 4 to 6 week stoppage of the levothyroxine and
Correct.
No,
Go ahead. Why are you hesitating?
sir,
So
serum
it
TSH
can
level.
be done in two ways. Either withdrawal,
Yes,
or you can give sometimes recombinant TSH. You can, if there is something that's available. So, but more commonly used is the withdrawal method.
yes.
So when there are high level of antibodies and everything against the thyroglobulin, a safe strategy is generally to have a stimulated thyroglobulin test where you withdraw you increase the TSH to a level where there is no other thing that is hampering the thyroglobulin to go up. So that would be more accurate in situations where you are having doubts with regards to your validity of your thyroglobulin level, because a lot of times there are ambiguous reports where thyroglobulin may be 7, 9 or whatever. So in those situations and in other few situations which I think is beyond the scope of this, I think this is important to know. It's important to know basically what is a stimulated TG test, right? What are the indications of radioiodine in the post-operative setting in thyroid cancers?
In differentiated thyroid cancer, intermediate risk and according to the risk category, intermediate and high risk category patient requires the radioactive iodine scan, sir.
Okay, sir. Could you elaborate some of the points what are intermediate and high risk patients?
In the high risk, if there is extra thyroid invasion, more than 5 nodes are involvement, and there is a T4B, and in the intermediate group, uh, there is a history of irradiation, family history is positive, high risk in the histopathological report, high grade of the tumor, they are included in the intermediate risk.
One important point would
Tumor
be
size is more than 4 centimeter in the high risk, 2 to 4 centimeter is included in the intermediate risk.
yeah, and one important thing obviously would be the presence of a metastatic disease, right, in a differentiated thyroid cancer, because that is one of the commonest indications why radioiodine is given these days.
Yes.
If we are to just circle back for the sake of completion, and I'm sure the senior sirs would have a point in this. Suppose you have done a thyroidectomy, you have explored the central compartment on post-op day 1 or 2, you have these things happening. what does it indicate, and CHOS takes science thing, and
Hypocalcemias.
yeah, and what are the modes of management that you would go for in those situations?
If there is a transient hypocalcemia, I would like to give the injectable calcium gluconate, uh, sir, with the vitamin D3, sir.
How do you give it?
Sir, 10 ml, 10% of the solution in 100 cc NS, 3 times a day with the vitamin D3 supplements. And after that, I would like to switch over to the tablet calcium with the vitamin D3 supplements.
Okay. So you said about this follow-up thing. Are you aware of a term called dynamic risk stratification?
No, sir.
Arvind sir, would you like to?
I think it's good. I think we can keep going more and more in the terminology, but I guess
Hmm.
yeah, I think it is there. It is a well-known term described by you. There is a Michael Turtle who actually described it from the MSK team, and it's something of a continuum of risk stratification based on 4 categories, like complete based on your responses.
It's based on
Complete
responses.
biochemical, complete, then structural. So there are 4 category and indeterminate. But again, these are all maybe for gold medal, Aditya.
Yeah, I know. I'm just, sir, we are just discussing it on a broad term. So I just
Yeah,
thought
yeah.
you might read it. I won't be.
So I think you all, I think if people are interested, read this article by Michael Turtle. I think he was a proponent of the dynamic risk stratification. It has been there in the ATA guidelines also. It's getting much more refined as well. And the basic premise is that in the follow-up period, the risks are not sort of constant. They change over time. Like, for example, if there's an intermediate risk in a long-term follow-up of an intermediate risk, if the patient keeps doing well, then they sort of they go into the low risk category essentially. So it has some implications in prognostication of the patients and in how much you suppress the L-troxin. So a lot of other therapeutic implications are also there with this. But it is a new advance, not new. It's been there for more than about 10 years now. But that is something that we keep following. So you read the publication, and then you'll get to understand the 4 categories and what are its clinical and the prognostic implications.
Yeah, to complete the various, so we have come across a lot of discussions to complete the discussion. When you talk of prognosis of the malignancies, are there scoring
Yeah.
systems or various factors which are included? Are you
Sorry, sir. The voice is.
various factors, to assess the prognosis?
Yes, sir. There is AGES, or there is different factors. AGES, according to that, age, grade, and size of tumor, extrathyroid invasion is there or not, and there are other AMES, MACIS in the composition, and the metastasis is also involved, sir.
Fine. So we need to be aware of just to complete the discussion before this. I think we have covered almost all the points. Yeah.
Right, sir. Srinivasan, sir, anything from your side?
Thank you, sir. Well done, Lavish.
Aditya, regarding ISTS.
Yes, sir. If I may be allowed to just show
Yeah,
some
yeah.
slide. Yes, sir.
Lavesh, हमने share करो. Let
Yes.
him.
Yes.
Yes.
Sir, can it be seen, sir?
Yeah,
Yes, yes, sir.
we can
Yeah,
see it.
so for all the doctors here, especially the residents and the senior faculties, this is the Indian Society of Thyroid Surgeons. It is the 7th annual meet that we are hosting in the month of September, 26 to 28 September. So there are many international faculties and very prominent national faculties. Arvind sir and everyone is included. So we are doing this whole 2.5 day thing with a pre-conference live surgical workshop and thyroid ablation workshop also, because that's the new thing in town. And so this is a comprehensive workshop that should entertain everybody's curiosities and all, especially for the PG students. It is something that I think everybody should enroll in because it's coming home to Ahmedabad. This is a very prestigious event, and there are multiple faculties from all over the world that we have invited. So It's just a request to everyone to register for this. The rates for PG students are subsidized. Early bird, it has been written here up to 15th May, but we have extended it up to 15th of June. So we have the next 4-5 days. So in case you people are interested, you can check out the website of this, and there's also this code that you can take a screenshot of, and you can register via that too. We have had wonderful support from Apurva sir, Pankaj Modi sir, and everyone that has been around also. And they are also prominent organizing members of our ISTS. So I would request everyone to register quickly. And for the residents, if there are any papers that you would like to publish or abstracts that you would like to submit, which would help you in, of course, your exam also. There is scope for that. We are extending the deadlines of the abstract submission up to 15th of July. So it's a request to everyone to register for the conference. It's likely to be a wonderful event, and it's practically home. So there's not much problem with regards to travel and everything. And it's obviously the time of Navratri, so I'm sure everybody will be here. So those visiting from outside will also likely have a wonderful time. So a request to all students as well as the seniors here, sir. It's a conference for everyone, for ENT surgeons, general surgeons, seniors, head and neck surgeons, and oncologists. And we are also involving endocrinologists and others in this, so that it's a comprehensive thyroid event. Basically, it's not just related to any cancer or anything.
Yeah, I am already registered, sir. The only thing is regarding abstract. Is it related to thyroid only or?
Yes, sir. This is a yes, sir.
Right.
Thyroid related only. Yes, sir.
Okay, fine.
Yes. Okay, sir.
Okay. Any final points, sir, or can we sign off, sir?
अपूर सर, आप सभी कॉन्फ्रेंसेस अहमदाबाद में ही हो रहे हैं आपके. कोलोरेक्टल also we are having from 11th to 14th in Ahmedabad. Now they are inviting again to Ahmedabad. Next year you want ASECON in Ahmedabad. All cricket matches in Ahmedabad. So you want us to stay?
Sir, आप आ जाइए. हमारा घर आपके लिए हमेशा खुला है. Please come down and just let me know.
11 to 14 में तो आपके पास ही है कोलोरेक्टल के लिए.
Swarnim Gujarat, sir. Absolutely.
Thanks, sir. Thank you, Arvind sir. Thanks
Thank
for
you, sir. Thank you, sir.
Joining us. Srinivasan sir will bid you a fine then. We'll go.
Thank you, sir.
Thank you, sir. Thanks for joining.
Thank you,
sir.
sir. Thank you.
Thank you. Thank you.
Thank you very much, sir.
Lavish, well done.
Yes,
And good job, Lavish. Good job.
Yeah,
Sure.
thanks,
Lavish.
Lavish. Yeah.
Well done, Lavish.
Thank you, sir.